Thank you for choosing Axxess On Demand. Axxess believes in continuing education, and we create content to empower you to learn and grow anytime, anywhere. Let's get started.
Hello. Thank you for joining us for today's webinar, Overcoming Challenging PDGM Intake and Coding Scenarios. My name is Molly Casey, and I'm on the marketing team at Axxess. Axxess is a leading home healthcare technology company offering a complete suite of easy-to-use, innovative software solutions that empower home health, home care, and hospice providers to grow their business while making lives better. Today, you will hear from Sharon Litwin. Sharon is founder and senior managing partner of 5 Star Consultants, a national consulting and coding firm specializing in home care and hospice services since 2003. Sharon was an ACHC and CHAP surveyor, performing Medicare germ-deemed surveys for 10 years. In her consulting work, Sharon assists home care and hospice agencies in providing quality, meeting regulations, ICD-10 coding, OASIS, increasing outcomes and star ratings, and having continued survey readiness. Sharon and her staff perform ICD-10 coding and OASIS reviews, QAPI, clinical record reviews, mock surveys, and help agencies across the country stay in compliance. Sharon is a regular speaker for education companies, state and national associations, and publications. Before we begin, a couple of quick housekeeping items. You'll notice the slides are currently available in the handout functionality of GoToMeeting, so you're welcome to grab them there. Your phones have been muted, but you may submit questions throughout the webinar. We will follow up with you to respond to those questions after the webinar. Slides from today's presentation, along with a recording of the webinar, will be available afterwards and will be sent to all registered attendees via email. They will also be posted on axxess.com. Okay, Sharon, we're delighted to have you today, and we look forward to hearing what you have to share.
Great. Thanks, Molly, and welcome, everyone. We're going to really be digging into different scenarios you find, not just on coding, but on intake and skilled need, etc. So I think that it's always been a very well-received class because it's really taking situations that you will see with patients and looking at it under PDGM. What are the variances? So this class is a long class, and so we're doing this just for 60 minutes today. It'll take all of that time, but you can email me and Molly or actually put your questions into chat, and Molly's going to send them to me, and I will get back to you. So please put your questions in chat as we go along. The beginning part is all basically talking about PDGM rules with coding. So we're going to just skim through those. I hated to take that out because it is a refresher and it's also material you can look at as you're going through the scenarios. But the bulk, I want to definitely do the scenarios. So of course, 2 of the 5 PDGM subgroups are directly related to coding. I told you what we're going to be doing. You have to remember that the coding conventions and guidelines have not changed. We need to follow those. A lot of agencies, a lot of people contact me and say, okay, well, how did PDGM change coding guidelines? And they haven't. We do have areas with coding that we have to follow, but it hasn't changed the coding guidelines, such as our excludes 1 and 2 notes, our manifestation etiology codes, etc. We have to follow those. And in fact, you know, it's almost October. I start later in the week doing our coding updates classes. So we're already getting the updates on the coding guidelines, but PDGM did not change them. You always code to what the physician documents. Very important. A lot of querying to the physician, and we're going to talk about how critically important that is at intake and then at initial assessment before you really admit the patient. You always code with the information from the comprehensive OASIS assessment. That's where you'll get maybe your Z codes, such as you'll code the oxygen such as person living alone. So that comprehensive assessment, the narrative that the clinicians put with it is very important as you put the whole story together. We have about 60 RNs, and we do coding and consulting. But for our coding division, there's about 50 RNs, and all day long they are putting that story of the patient together between what the physician gives, H&Ps, consults, face-to-face, the referral, with the comprehensive assessment, the narrative, the therapy evals, the meds, the orders, that whole big picture. But really, bottom line, you want to have it all to tell the story, and anything you don't have, you have to query the physician for as far as diagnoses go. So quickly, PDGM, the primary diagnosis, gives you the clinical group, a big portion of the reimbursement and the 5 groups. There are 12 clinical groups. We'll talk a lot about that in the scenarios, as we will about the comorbidity adjustment, is from the 24 possibilities of secondary diagnoses that you put in, notice reported on the claim, because OASIS only goes to 6. So you have to be sure your EMR, you're putting it in the right place so that you have those secondary diagnoses also flowing to the claim. You get none, low, or high. This tells you a little bit about OASIS I just talked about. So these are the clinical groups. I know that you've seen these tables a lot of times already. This is the low comorbidity adjustment group. And these next 3 are the high comorbidity adjustment interaction subgroups. Is that the full name, the full mouthful? So as you look at this later as train the trainer, if you're in your agency as the only one listening, you can do this as a real scenario workshop where you're putting the scenarios out and having your team take a few minutes to answer them, and then you discuss them. Okay, but for today, of course, you have the answers in your handouts, and I'm going to go over them right away. So we're going to talk about a hospital referral to the home health. So your intake department, let's say, received a fax referral from the hospital discharge planning department for Mr. H, asking if your agency will accept the referral. So it documents that the patient was seen in the emergency room after falling at home in the bathroom. The patient reported he had been having diarrhea for the past 4 days. The face-to-face documentation in the referral lists the diagnosis as muscle weakness, M6281. For the coders in the room, I'll always give the codes as well, but this is for many more people than just the coders. R29.6, frequent falls, services needed, and PT for safety eval and strengthening. So what do you think? Do you accept this referral under the era of PDGM? Well, the referral as you received it, it doesn't support the need for home health services. It's an unaccepted primary diagnosis. I used the simplest one to start because I'm sure you all know that muscle weakness is one of the thousands that we cannot put as primary, and also was the one that was most used as a primary diagnosis by home health. And so that right away causes an issue at intake. So the key thing is contacting the referral source and explaining that we can't do it if we want to. We can't put it in as a primary diagnosis. It will be kicked back to us. What CMS wants is the underlying cause of the muscle weakness. So that has to go to the referral source and to the physician. So, once we talk to the referral source, they faxed additional H&P information from the hospital, which showed that the patient was diagnosed with C. diff and is being treated with antibiotics currently, was found to have hyponatremia and hypokalemia, and those are both resolved. So now we have A04.72. And, I've been a coder for a long time, about 10 years. I've been a consultant for like 20, but coder for like 10. And for those of you that aren't coders, yes, the numbers that you see, the letters that you see, and the definitions, that is true. If you look up just C. diff, it's kind of difficult to find. Enterocolitis due to Clostridium difficile, I'm going to say C. diff. not specified as recurrent, and this could be the primary diagnosis for home health. It's an accepted diagnosis. It's the underlying reason for the muscle weakness and, of course, the diarrhea. Now, you have to make sure that the physician's okay with that. You're going to have to query them. And, of course, whenever I say physician, we can be talking about the physician's nurse, you know, that gatekeeper that's going to get the information to the physician and get his information back to you. So we have to ask him, is it okay if we put C. diff primary? Because we're saying that's the acute disorder that's still being treated, and it's the underlying reason for muscle weakness, which we cannot put as a primary diagnosis. And then that would be reflected in the medical record of the physician and the hospitalist, because that's in the face-to-face documents is all of that information on C. diff. So if the physician approves, then you can put it to that. And then, of course, the PT can go in and see if any other nursing services should be recommended to the physician if they're still having diarrhea or other issues, etc. So that communication with the referral sources at intake and the physicians at intake is critical as you move through PDGM. All right. So the second scenario, a physician office referral. So this is from the office for Mrs. W, and they say that the patient's family phoned the doc's office reporting that she fell yesterday at home. They took her to the emergency room, and now she's having difficulty walking. So the physician requests the nurse make an evaluation to assess the situation. So do you accept this referral? Well, you know, there are a lot of options, and I'm even going to add a D option. But if you could refuse to take the visit because you say you know that only certain diagnoses are accepted and this patient, you know, fell at home, does she have a skilled need? If it's primary of difficulty walking, we can't use that. Or you can make the visit and phone the physician with the updated findings. You can explain to the physician's office that the diagnosis provided are unacceptable under PDGM, request additional information, and why is the patient having difficulty walking, and could that be a reason? Now, the D option is also, during our COVID waivers, you are able to do that initial assessment by phone. And so you can get more information from the patient and family to identify if the patient has, number one, skilled need, number one, an appropriate diagnosis, and of course, homebound, so that then you could give that information to the physician. If you refuse, it may be the last time that referral sources gives you any more referrals. We all know that. Now, we also know that everybody across the country should be refusing those types of diagnoses. But if you really go further, that's better. Now, making the visit, if you're making a comprehensive and initial assessment visit together as a start of care, that could negatively impact you because maybe there isn't another reason and you can't take the patient, which is really difficult at that point. Of course, a lot of times you're going to find out that there are a lot of other reasons that then you would be able to admit the patient after you query the physician. But when you explain this to the physician's office, that's so important because they have to know this for future referrals. And so you're saying that we can't take a patient for difficulty of walking, but why is that? Why is the patient falling? Why do they have difficulty walking? There will be an occasional patient here and there that there is no reason. The doc says it's only for this, and goodness, we can't do that under PDGM. But like I said, typically, you know, in a lot of percent, we have seen so far that agencies are able to take the patient, that the physician agrees once they see what the underlying diagnosis is. But you have to have this really established process for referrals so that you are sure you get adequate, acceptable diagnosis information. And so your intake department really has to be educated on PDGM coding. You can't say we're not going to educate anybody but the coders because they have to know this. Now, Will intake know the 130-some thousand codes in the code book and know how to put the codes in for everything? Of course not. But they really have to be very savvy about what is not accepted as a primary diagnosis under PDGM, so they can put a stop to it right then and get the information before you have a lot of time delays. Because you figure, if I'm doing your coding and OASIS review, now the referral comes into your agency, your nurse goes out and does the OASIS and all of the comprehensive assessment. You send it to me to review. I start to review it, but I can't finish it. I have to send it back as a problem chart because I can't code primary diagnosis of difficulty walking. So you go all the way back and say, if we did this at intake, we would have not had a time delay and possibly lose money on admitting a patient we can't admit. All right, the third one is a doctor's office referral for PT. We're doing, a lot of these PT ones because that certainly has been the most common of what the unacceptable diagnoses are that home health uses as a primary diagnosis. So this time the doc's office sends a referral for a patient for the PT for ataxia. And the patient was seen by the doctor yesterday, which is good. Now the administrator who made the call doesn't have any additional information, but says she'll fax the note from the office visit. Now this physician's note from his visit says the increased ataxia is due to patients worsening Alzheimer's and dementia, and patient is no longer able to leave the home safely. Unfortunately, a lot of times the referrals will say the immediate issue, ataxia, but of course in this case you would have hoped that it would have said due to patients worsening Alzheimer's and dementia, but since it didn't, that's what you have to get. Okay, so now in this case, of course, we code the primary diagnosis as G30.9 Alzheimer's. The secondary diagnosis is coded as the dementia in diseases classified elsewhere without behavioral disturbance. That means that's the dementia code you have to use with Alzheimer's. And then R27.0 ataxia is after that. So you have to code following the etiology and manifestation codes. You have to have the underlying condition. So that's why Alzheimer's is primary. Dementia has to be before ataxia because of the coding guidelines. And then ataxia is coded, and the guidelines state to code for signs and symptoms that may not be reported, and you would code that after the diagnosis and the manifestation code. All right. Now, if the visit note from the visit yesterday didn't say anything about any disease process causing the ataxia was new, you're going to have to query them for more information. And you'll ultimately need that definitely documented because that would be your face-to-face then. Okay. A physician referral for a sick patient. This has been very common over the history of home health to get calls from a doctor's office asking you to make an eval visit on Mrs. V. The patient's family just called saying they think that she has the flu, but she's too sick to go to the doctor's office to be seen. Now, guess when we wrote this? We wrote this class in January. We were coming up with all the scenarios, and of course, we've added some since then. We've added some COVID ones since then. So, of course, they're not going to call you saying they think she has the flu. What are they going to call with? Of course, they think she has COVID. And now, unfortunately, flu season's starting, and now we're going to have that question, is it the flu or COVID? But this is the type of scenario that happens to home health agencies a lot. The patient's too sick to go to the doctor's office to be seen. So what do? Well, the referral's questionable. So what you can do is complete an initial assessment to determine if the patient meets eligibility criteria. The best thing is not to run right out there. During the COVID waivers, the 1135 waivers, they said that we can do an initial assessment remotely to determine immediate care and support needs and their eligibility, including homebound status. So by making this phone call, you can also do it with AV, Skype, and or I forget the other one on the phone, FaceTime. You can do that during the waiver. After the waivers, probably our initial assessments will go back to on-site, and certainly they wouldn't be okay with a phone call for the initial assessment. But for the waivers, you can. So this is my recommendation. You do this initial assessment, which is basically a phone call, finding out what's going on with the patient, and if you truly are able to admit them for home health. Now, you have a challenge, and that's the face-to-face documentation. So, of course, we know you can have face-to-face for 90 days prior and 30 days after start of care. So before I talk about the COVID waivers, this is a dilemma because is the patient going to go into the physician soon? Until you have that face-to-face, you can't get a signed 485. It's holding up everything. And then if you don't get a face-to-face, forget it. You can't bill for a thing. And so, that lack of face-to-face, you have to have a very tight process on who you're going to admit if you don't have a face-to-face at the beginning. Now, face-to-face during the COVID waivers is easier as well. You can literally make the visit as the clinician. You can be the one that does the face-to-face because a lot of patients aren't able. Now, maybe they're families or maybe they're very savvy. Maybe they've gotten extremely savvy with Zoom since COVID has started. And so they can do that face-to-face as long as they can see the doctor in real time. I literally just last week on Friday, I did a virtual vet visit for my dog because he hurt his leg. He already has arthritis and he ran down the steps and he's crying like a baby. And so now even the vets, I went on with my vet, did a virtual visit, had to go pick up the drugs then, and then we went on our way. Well, we can do that for our face-to-face during the COVID waivers. Boy, we wish we could all along, but I doubt that they'll keep that as it is. So now that can't just be a phone call, but if the nurse wants to go in and at that comprehensive visit or even the next visit or so, I wouldn't put it off because you're not sure, then you get the doc on the on FaceTime or Zoom or Skype, and you get the patient and the family on that, and then you can mediate that or moderate that, I guess is the word. So that's the best way. After the COVID waivers are lifted, this is risky because the patient's too sick to go in with the flu. Well, is she going to want to go in afterwards? So that's going to be problematic. So again, this is all about, with face-to-face and with just saying the doc hasn't seen him, go check on the patient, family thinks they have this. This is always best not to accept. Now, I've been in home health for 30 years. We got those all the time. Those were the classic referrals. We would always go in to eval and assess and then decide from there and call the doc's office. But those days are over. Okay, so a doc's ordering speech therapy for home health. And it's on a 97-year-old man, and he was just seen in the office today and had difficulty swallowing. The physician's visit note, which you get, you always want intake to get those visit notes because that is basically your face-to-face, and you really have the information you need. Per the patient, trouble swallowing has been going on for a couple of months and is progressively getting worse. Gosh, we didn't get an underlying diagnosis, did we? Getting worse from what? What's the dysphagia getting worse from? But the diagnosis the doc gives you is R13.10, dysphagia unspecified, with an order for speech therapy to evaluate the dysphagia. So can you accept this referral? We don't have what the underlying diagnosis is. Yes. And a lot of agencies still don't know this. About 3 weeks ago, I got a call from a gal that I talked to a whole lot at a state that I, am real involved with. And gosh, I thought she knew for sure. She came to my 2-day on-site PDGM classes in the fall, etc. But she didn't. So I think so much happens that you just overlook stuff. But when it went from a proposed rule, when we were all screaming about take away all these unaccepted diagnoses, we can't use any of the R chapter, which sure it's signs and symptoms, but a lot of times that's all we have, such as dysphagia. And, hey, you know, you took away the muscle weakness and the falls and the difficulty walking and the bradycardia and the shortness of breath. A lot of times we don't get what the underlying diagnosis is because maybe the doctor doesn't know. But in this case, the only codes they added for the from the R chapter, the only thing they gave us back was the 6 dysphagia codes. And so these codes, even though we don't know the underlying reason for the dysphagia, can be a primary diagnosis for home health, and speech therapy then should be going in if it's a primary diagnosis. Okay. Now this is another referral where the physician's office gives you an unaccepted diagnosis. So the physician referred for physical therapy for muscle weakness. The patient has diabetes and hypertension as their comorbidities. Now, the intake nurse from home health contacts the doctor's office nurse and says, the organization, we can no longer take a primary diagnosis of muscle weakness because of PDGM rules. But the home health nurse asks the physician's nurse if they think that a primary diagnosis can be muscle atrophy or wasting, because that's actually what CMS put as an example in the rules. But the doc says, no, they don't have muscle atrophy. That's a different condition. He says Mr. X is elderly and debilitated and prone to falls, and that's why he needs PT exercise for strengthening. That is exactly why CMS said we can't use it as a primary. They said we're using it on older people that are debilitated, and we want to make sure they don't fall and be okay, and no, you can't use that as a primary. We, of course, all disagree with that, and we've all been fighting that, and hopefully someday that will change. But for now, that's how it is. So the home health nurse says, can we use diabetes as the primary diagnosis? Because that's fine, and he has diabetes. The physician says yes, and even states he's going to change it to add more on the diabetes in the face-to-face. So the admission happens in home health, and they put the primary diagnosis of diabetes, E11.9. The comorbidities are muscle weakness, hypertension, and fall history. Is this an acceptable solution to the muscle weakness? No. You can't lead the physician to put a primary diagnosis that isn't appropriate in order to admit a patient. In Mr. X's scenario, he didn't have changed meds. His blood sugar was stable at 110. He had no signs and symptoms of hyperhypoglycemia. His diet was managed. So diabetes is not an appropriate reason to admit Mr. X. Also, if you do it anyhow, and then you get an ADR on it in the future, it's going to be denied because of all those reasons. Everything is stable. All you're going to be doing for Mr. X's diabetes is watching what his blood sugars are that he logs, doing an assessment with really nothing else. And so that comes across so clearly as you look at a chart. Now, we review charts like that all the time. We review for QAPI, we review end of episode, etc. And no, you can't put a different diagnosis in there that the patient has if that's not your primary reason for home health. And you can't lead the doc like that. If, you know, it was fine to say, well, you know, CMS says that an alternate for muscle weakness is muscle atrophy and wasting. But we all know that that is truly not typically the alternate that you can put. So in this case, as it stands, his hypertension is stable too. There's not a reason that we see that we can admit Mr. X to home health. Occasionally, this will happen. All right, a little bit on Z45.2 before we go to the scenarios, that's the IV code. Now, you would never guess that. Look at that. Encounter for adjustment and management of vascular access device. I haven't looked for a long time, but I think if you look up IV, you're not going to get led to that. Maybe if you put intravenous access device, vascular, etc. I know if you Google it, you do. So you put what is the ICD-10 code for IV, you'll get Z45.2, which is a good thing. Anyhow, that is what we use for IVs and all types. And so that can be the principal diagnosis, it can be the first secondary diagnosis, or it can be in any one of the 25. If you're only doing care of vascular access device and no other care is being provided, then Z45.2 can be primary. There's been a lot of confusion with this, both from the coding clinic as well as then finally clarifications. So in a case where the patient's receiving an IV antibiotic for sepsis, per the coding guidelines, sepsis has to be coded as the primary diagnosis. CMS instructions are that the IV is not the primary reason the patient requires home health, but where there may be some sort of intervention noted on the home health plan of care, it would be appropriate to report Z45.2, but not as the principal or first secondary diagnosis. Put it down lower like we did for years. It was a lot of confusion at the beginning because the first secondary diagnosis kicks it into a different clinical group. It's one of the only ones that it does that for. So I'll show you in a scenario, the patient sepsis with IV antibiotics. You receive a referral, the patient's admitted from the hospital, he was admitted with sepsis, UTI due to E. coli. Now, the patient has a PICC line in place and is being discharged home with IV antibiotics for an additional 5 days. So how could you code this patient? Okay, so primary diagnosis, you would code A41.51, sepsis due to E. coli. That is a clinical group of MMTA infection. Now, if you coded as the coding guidelines say to, N39.0 UTI is what comes next. Now, it's okay because the next you put, or maybe you put it as the 24th code, Z45.2, you put IV. And that's okay. That's how we've coded it for years. The dilemma was, are we supposed to put it as the first secondary, but then how do we follow the coding guidelines with the first secondary? But look what happens when you put the same diagnoses and you put Z45.2 first, it flips it to a clinical group of complex nursing interventions. And if then you put the N39.0 UTI, well, you're supposed to have that following the A41.51, and that says complex nursing interventions. Whereas clinical group MMTA is infection, which makes more sense. You're following coding guidelines, and CMS said this is appropriate in the recent clarification. So that solves that initial problem that it has to be down as the first primary diagnosis. No. So if you haven't seen that last CMS clarification, it's very important too. Okay. So number 8 is a change in the 30-day coding, but actually a change in the patient's situation. So those are typically called a SCIC, right? Significant change in condition. Well, not always, because PDGM says if in our plan of care, we know something's going to change and we know it's going to be different at the end of 30 days when we have that second 30-day payment period within a 60-day episode. Very confusing if this is the first time you've heard about PDGM. But our episode, our certification, our 45 is 60 days. That didn't change. But the 30-day payment periods stand alone. So you probably want to change a diagnosis in 30 days if you have something planned that's going to change. In this case, it is post-op abdominal surgery wound care. The order is to change the wound dressing every, 3 times a week. The patient has diabetes and COPD as comorbidities, but it even says in the referral everything with that is stable. So basically, we're going to look at everything with the surgical wound, and of course we're holistic, but the reason we're there is encounter for change and removal of surgical wound dressing. That's a clinical group of wound, Z48.01. We expect, and our goal on the plan of care says the wound's going to heal in 3 weeks. Of course, we have goals and interventions for wound care. But then, of course, we mention the diabetes and the COPD because, of course, they are systemic, ongoing diseases. But they're all stable. Now, at week 4, or maybe I should even say week 3, the wound is healed. So what happened was exactly what we expected. But the patient hasn't really been following her diet since she had her surgery. She got used to having the ice cream that she had at the beginning, and she's not eating well at all. And so her blood sugars are over parameters that the physician ordered. So the doc orders new diabetic meds and even a dietitian. So our wound heals as planned. We don't discharge the patient because now we're going to be looking at more diabetic interventions. So the doc says, yes, keep her on for diabetes. So now we do that before the start of the second day 30 days claim, we're going to then be switching this to diabetes. We get a doctor's order. We change on the order to 11.9, change that on the claim, and now it changes us to MMTA endocrine. Of course, we don't still want the wound dressing on for the full 60 days because that's healed, and now we're working on diabetes. Now, this was a planned situation. Your agency has to decide when you're going to do follow-up OASISes for SCICs, significant change in conditions, or not. In this case, you may very well say we won't because we knew that the wound was going to heal and we knew the patient had diabetes. But if the patient's diabetes really went way out of whack and was up to the 400s and had to go into the doctor and now is an insulin, of course, then that's a significant change in condition and you would do the follow-up OASIS assessment. If you do an OASIS, then those functional impairment items would then count for that 30-day as well. And when you put the diabetes as primary, the other secondary diagnoses, if you change them, would count for that 30-day as well. Okay. Another example on 30 days, patients admitted with COPD exacerbation, J44.1, COPD, I said that. That's the MMTA group, clinical group of respiratory. The patient falls on day 25, has an ER visit, gets a severe injury, a laceration of his lower leg with no hospitalization. So now we do the follow-up assessment, OASIS. That's an RFA 5. It's called an other follow-up. So PT is ordered. The nurse is now ordered to do wound care 7 times daily and then 3 times a week. So at that second 30 day, her COPD exacerbation is now just COPD. We got her out of the exacerbation. But now we're there a lot because now we have to do the wound care for the diagnosis requiring the most intensive service. And so that is a clinical group of 1. That's laceration to the left leg. For you non-coders in the room, yes, it's really true. Every time we code a laceration, we have to look up and get to a 7-digit code, S81.812D. And so, yes, coding is complex in these day and age, and you have to make sure you have expert coders, not your clinicians that are in the field doing the coding, as we still see sometimes. All right, this switches gears. This is when I'm reviewing a clinical record. I'm doing a record review, and the patient's in the second episode of care. primary diagnosis at start of care and at restart with CHF. The patient has nursing and PT, but there's a lack of skilled needs seen in the documentation for home health nursing. And I don't really see that there is actual skilled need. So I ask, I've done this many, many, many times in my career, and either, now by electronic, sending an email or getting on the phone, or many times when I'm on site at agencies all the time, why are you still seeing Mrs. Jones? And man, I can't count the number of times that nurses, including the clinical managers and directors and sometimes administrators, will say, if we don't keep seeing the patient, they're going to worsen because their old habits are going to return. They're going to be non-compliant. They're not going to do what they have to do. They're going to get worse. They're going to exacerbate, go into the hospital, and that's why we have so many frequent flyers. Isn't it better just to keep her on for a lot of episodes? We know CHF is chronic. Yes, I'm a nurse. I say that is better. That is great care. That's what should be done. Medicare, who is the boss, says no. Says nursing and home health, you're going to have a skilled need. Once you get them under control, you can only assess for 2 or 3 weeks and you have to discharge. So nursing denials come for this all the time. I have several clients over this past year, I guess year and a half now, I should say, that have had little agencies with so many ADR denials, and this is what you see. And when we work with them to see how to appeal, I typically say appeal, but that they're denied because there is no skilled need under Medicare. Now, let me talk about therapy. Therapy is different because the Supreme Court ruled about 5 years ago that yes, if the patient, this is the caveat, the patient has to have a debilitating condition. If they have a debilitating condition, Parkinson's, on, and here we put rheumatoid arthritis. That's a clinical group, MS Rehab, and the PT is going to stay in on this patient. It could also be OT and ST. Can stay in under maintenance therapy. It's to prevent the decline, exactly what we need to do for patients. We met the improvement goals, and now we're going to prevent the decline. Now, you have to know the rules for maintenance therapy, but honestly, I teach it a lot, and it is mostly the same rules. You have to have skilled needs. You have to have goals. Your goals are going to be the main thing that changes. And you have to have the interventions. You can now use the assistance. So there's a lot of opportunities for patients with debilitating conditions to have physical therapy or therapy services on as maintenance therapy. So there's a knowledge deficit in a lot of agencies and a lot of clinicians on the fact that the nurse is skilled need, certainly the therapist skilled need, because I told you, even if they go to maintenance therapy, they're still working on a skilled need. So we wanted to include that to help you with those areas. All right, primary diagnosis effects on comorbidity adjustment. This is important because I know I don't code a lot because obviously I have a big role and I'm teaching so much, but I teach coding a lot. I have to, of course, not be rusty, right? So I code 3 or 4 patients a week. And we have all seen this since PDGM, that agencies want everything under the sun coded. They want to get to 2025 diagnoses because they want to get comorbidity adjustments, and they specifically want to get high comorbidity adjustments. That doesn't happen. You only get comorbidity adjustments for what are on those tables, and there's a lot of things that don't count on there, especially for high comorbidity adjustments where over half are wounds. So, you don't have a heck of a lot of the time that you can, and you can't put every resolved diagnosis or every diagnosis the patient has had for years and years that don't affect the plan of care for home health. those that are, you know, a bunch of Z codes, X codes, all of those, you don't need to put 25 to ensure you get a high comorbidity adjustment. That's not how it works. It also changes very much as what is the primary versus what's the comorbidity. So in this case, the patient had an exacerbation of diastolic CHF, has HTN, has a stage 2 pressure ulcer to the coccyx. So skilled nursing's ordered 3 times a week to monitor cardiac status because it's an exacerbation of diastolic CHF. Response to meds, but also we do wound care 2 times a week. So I'm not going to get into the codes for time frame, but by putting the CHF exacerbation at the top, following coding guidelines, so you put the CHF, then you put the stage 2 pressure ulcer. That gives you a high comorbidity adjustment because the CHF, diastolic CHF, I50.31, and the stage 2 pressure ulcer, L89152, is on interaction group 17, heart 11, and skin 3 of the tables for high interaction. So you have to go back to those slides when you print them off and look, and that's where you'll see it. So you get a high comorbidity adjustment. Now take those same diagnoses, but now the patient's not exacerbating with their CHF, and now the referral for a patient with stage 2 pressure ulcer alone, but then, of course, the comorbidities. And so now the doctor's ordering, the primary reason is for wound care to the coccyx pressure ulcer. So now we have to put that primary, L89152 is the stage 2 pressure ulcer. Secondary, we put the diastolic CHF and the hypertension. And we are in a low comorbidity group because we have both HTNs in the comorbidity subgroup 11. Your primary diagnosis is not factored into the comorbidity adjustment. It stands alone as a clinical group. So when you have to code something as the primary reason, that is the primary, then that doesn't count. And agencies, I get probably more questions on that than anything else. Okay, so 12 is a missing discharge summary. We give you several scenarios under this. The first one is that Mrs. Z is referred to home health agency for post-op care. Simple, we're going to say gallbladder removed. The only information given is that the patient's debilitated, weak, has difficulty walking, and lives alone. So the agency admits code Z48815 for encounter for surgical aftercare following surgery on the digestive system. That's clinical group MMTA surgical aftercare. You don't get a comorbidity because the only secondary diagnoses you put are debility, weakness, difficulty walking, and lives alone. What do they have in common? There are codes, which unless it's dysphagia, you can't use it as a primary, but also they don't count as comorbidities. Definitely put them as secondary diagnoses, but they don't count. We definitely need that the patient lives alone. That's a big part of the story and why we're in home health, and that's a Z code, but it doesn't count as a comorbidity. So here, I don't have time to go through as we ran through the whole scenario for the HIPS code and the case mix. And by the way, these scenarios, we did all of them on Axxess. It was so easy to get all of this information in Axxess that for our scenarios, that's where we got the information that shows the HIPS code, the case mix weight, the LUPA, and the payment. So those of you that don't have that EMR, you have to make sure how you find that out in your EMR. Now, the next scenario, the patient's admitted for post-op care after having a gallbladder removed, but in the hospital ER, there's documentation in the discharge summary. The patient has, that should say hospital EMR. Sorry about that. The patient has diagnosis of HTN, CHF, and COPD. So now you admit the patient with the Z code for surgical aftercare for the gallbladder, and that's still a clinical group of MMTA surgical aftercare. But now we get a low comorbidity adjustment, because now we have those diseases, the hypertensions, the CHF, the COPD. Remember, you only get one. You don't get 3 low comorbidity adjustments, but you do get one. So here you'll see there's a little bit of difference in case mixed weight and a little bit of difference in money. And boy, a little bit of difference is so needed these days. The third scenario is, after the gallbladder is removed, then the discharge node has this information, but now during our start of care visit, we see that the patient has a wound on her left ankle. You know how that happens all the time. We don't get told stuff. That wound started in the hospital, but we didn't know about it. Maybe they didn't know about it. So we call, we say this, the doc's office actually says, oh yeah, the patient has chronic stasis ulcer because of venous insufficiency, and we receive wound care for 2 times a week. This scenario, you know, is so real. You have to dig to get all this information, and these 3 scenarios show you how. This is a high comorbidity adjustment. The clinical group stays the same, surgical aftercare, but now we have the peripheral venous insufficiency. We've coding guidelines, mean that's verse. The stasis ulcer is under the venous insufficiency, as the heart failure is under hypertensive heart disease with heart failure. Those are all coding guidelines. And the COPD, then comes all the R codes and the Z codes. So you can see how, and this just shows you the interaction groups that they're in. Once again, you only have the one high comorbidity adjustment, and you don't get an additional low. It's one or the other and only one. A lot of agencies think, let's pile these up because we get a whole bunch of them. No, you get one. And then this is the case mix, the HIPS code, the money, the LUPA threshold. So again, you can see a little bit of difference. It's enough that you have to pay attention to it. Okay, for time's sake, this is a great one to skip over. 13 is unspecified fracture laterality. The only reason we use this is because this is what we see so much in documentation. We don't see that there is laterality that the coder coded or that the clinician put. And you can't put unspecified, which then 9, if you look at that 6th digit of the 7-digit code, 9 means you're not telling us if it's left or right. You have to have a 1 or a 2 there. You have to say if it's left or right. And if a coder is coding in your agency and they code 9 because the clinician didn't document it, that's wrong. The coder has to get with the clinician who has to document it, who has to tell the coder. And so that is something that should never be seen, but it is. All right. So now, I already told you, when you see this code, go to the second bullet. This fracture of the humerus is of the right arm. The 6th digit says 1. That's right. And that's what's acceptable and can be used as primary. Even if this is a secondary diagnosis, though, I mean, you want to put right or left, whatever it is that has laterality, please be sure that's documented in the comprehensive assessment and is coded. Okay, coding sequencing. This is a huge one. I'll skim over, but boy, is it a great one to give your coders as a little test, not even a test, a scenario to work through without giving them the answers. Mr. C is hospitalized 2 weeks. He was initially admitted for amputation, diabetic ulcer with gangrene. He got, this is a typical home care patient that we see. UTI, treated with IV antibiotics, resolved. Lots of other things in the hospital resolved. But what he has is a history of PVD, HTN, CHF, chronic kidney disease 3, AFib, history of prostate cancer, BPH, urinary continence, and oh my goodness, he lives alone. Get an MSW in to see him, please. The surgical amputation's healing well, but SN is ordered for surgical wound care to the site 2 times a week, PT 3 times a week for eval and gait training and safety. So these are the things you would not code because they were resolved, including diabetic ulcer with gangrene because that was resolved by the amputation. We get people when we're reviewing charts seeing that coded all the time. Okay, so you have a big, long list. And how do you sequence? Well, the first one is the primary, the Z code. I had an administrator ask me about a month ago. Oh, no, and it didn't ask me. Said, Sharon, you are wrong. No Z codes can be used as primary diagnosis, and I wanted to let you know because you're teaching that. Okay, that's not correct. There are quite a few Z codes that can be used as primary diagnosis. I already told you Z45.2, all of the surgical aftercare, and many more. That is a myth that is out there about PDGM. All right. So now you sequence what is active and what can affect the patient's plan of care using the coding guidelines. And you can see a lot of the later ones are where you put many Z codes and R codes because that's giving us appropriate information. We want to know that the patient has personal history of, I hope I didn't cut you off. Has a personal history of UTIs and prostate cancer, etc. And we always want to know when they're on anticoagulants. So those are very important, but you typically sequence the disease processes first. Okay, this is a long explanation of that to show you where these various secondaries fall into. Do they fall into a comorbidity group? Some do. Some don't. So you can look at this and compare it to the chart to get a lot of good information. Here is where we calculated the hips, the case mix weight, LUPA, and the payment. Remember, it's for 30 days. So you look at this and say the patient has a lot going on. Well, you're getting $2,500 for that. Of course, you are having to supply the wounds. So you want to really look at that. In this case, your LUPA threshold is high. It's at 6. Okay, so now we just have a couple of COVID really quick and then some education slides I'll give to you to read later. I'll go through quickly. So if you can stick with me a few minutes. So the first COVID one is referral from a hospital for Mr. A, 50, who was admitted with symptoms of shortness of breath, at rest, cough, and fever for the past week. Obviously, the key indicators of COVID. He was diagnosed with pneumonia due to COVID. He has no other chronic conditions. He's sent home after a week in the hospital. He's sent home with oxygen and has to continue oral antibiotics. How would you code this? So this, your primary diagnosis is U07.1 COVID-19. Secondary is J1289, other viral pneumonia, and then the oxygen code Z99.8. The coding guidelines say for a pneumonia case confirmed as due to the 2019 novel coronavirus COVID-19, you assign U07.1, and then you assign J1289 after it, other viral pneumonia. You don't code the shortness of breath and even the fever and the cough because that is all integral to what COVID is and actually pneumonia is. The second COVID scenario is Mr. J. He has a diagnosis of emphysema, chronic obstructive bronchiectasis due to smoking. He's presumed positive COVID-19 and viral pneumonia. He's discharged home to continue with antibiotics for the pneumonia. He continues oxygen, which is not new. He continues to use an e-cigarette for documented nicotine dependence. How do you code? So again, in this case, primary is U07.1 COVID. Next is the J47.0 bronchiectasis with, I think I said that wrong, but with acute lower respiratory infection. Then the viral pneumonia, then the emphysema, then the nicotine dependence, and you put other tobacco product, and that's F17298. That's where vaping goes, and then the Z998102. So the COVID's not resolved. It's presumed, which is interpreted as confirmed for coding purposes. It's coded as primary with all the manifestations following, because these are disease processes. This isn't just the shortness of breath and coughing. He has a lower respiratory infection from his bronchiectasis, and so then he also has the viral pneumonia. Also, coding guidelines say that you code the emphysema because that's not excluded. That's not an excluded list from the above diagnoses. And then, of course, we have to put the vaping, which we now have a code for, and O2. The third one is Mrs. Z, another hospital referral for presumptive COVID-19. She had viral pneumonia and acute respiratory failure, complicated by a 15-year history of COPD, which was exacerbated. She recovered and went to rehab for 4 weeks for strengthening. Prior to discharge, the patient tested negative to COVID, but positive for the antigen. We've just started seeing these. So in this case, your primary diagnosis is the COP exacerbation, J44.1. Then Z8709 is personal history of other diseases of the respiratory system, then personal history of pneumonia, and then the O2. The COP was exacerbated, but it would have been primary, but now the patient tests negative, and so the history code is used. And so the pneumonia is, and the history code is that one, the Z87.09 is what we have for now that we're to code once COVID is gone, is negative, and now has the antigens. Okay, so I ran through in about 55 minutes a lot of scenarios. I skipped all the beginning part that when you're looking at the scenarios, if you go, well, why did she say we didn't get this high comorbidity? You can look at the high comorbidity checklist. And you can take this to the rest of your staff and go over this class much longer so that you can get your staff involved. Don't give everybody the answers. Get everybody involved. The intake's involved. The clinicians are involved, the coders are involved, so really everybody needs to be involved in this education. On the last page, I'll give you the NOC Physician Toolkit website links that I think are phenomenal. They have so many different ways for you to teach physicians. You can do a la carte for what type of referral source it is. But you really need to spend a lot of time with your referral sources that still don't understand the rules for primary diagnosis under muscle weakness, for the face-to-face, for the skilled need, etc. So, of course, you're not going to be talking to the doctors, but you need to get to the gatekeepers. Is that the nurse? Who is that in the office? And that's who you need to really spend time with to go over this. Otherwise, your intake has to stop these. The agents we see in trouble with cash flow, it's because they went through, right through intake, right through the initial assessment, right to where the nurse is admitting, and it takes them several weeks to find out that this patient doesn't have a real skilled need, that they put a different thing other than the unaccepted diagnosis, but now it doesn't match their face-to-face, and now the diagnosis that's primary isn't really the primary reason they're there. We're seeing this all the time. You have to stop it at intake. You have to all learn how to query the physicians. I don't know if I have a slide on this one for that, but querying the physicians specific to what the referral source wants. So you may have to have 5 different ways: electronic, fax, phone call, whatever, leaving a message with the office person. You have to do it how they want. But what's the best way to query so that we don't bug you too much, but we get the answers promptly? I mean, they have to do it. Okay, so coding, if you come across where what you're being told to code is an unaccepted diagnosis, you send it back immediately to the clinical manager or whoever, because we can't code that. If you put an unacceptable coded diagnosis in as primary, it's kicked back when you put the claim in. So you have to find that out. So then you really want to educate. Keep these from reoccurring. Educate, educate, educate. Okay, so make sure that the coding, you are putting all the secondary diagnoses that are affecting this patient's plan of care. That's definitely anything systemic and long-term, like diabetes, COPD. I have fibromyalgia. That's something that's significant, because when I get sick, that exacerbates. So many things like that. But do you always have to code hyperlipidemia? Do you always have to code every Z code in the book? No. And a lot of agencies think they can get to high comorbidity by doing this. Coders, use your grouper tools. If you're have the CMS grouper tool, you can run scenarios before you put it into your EMR. I never have said use that in the past, but it really is very user-friendly. And when you put a diagnosis as primary and those as secondary, it tells you by color which of those could be a clinical group and which of those could be comorbidity, low or high, and which have nothing. So it's very helpful. Okay, be sure that you do coding audits, and that's whether you're using in-house or outsourcing. You know, audit the coders, because you have to have, coding is an expertise. It's very difficult. You heard me say that I have to keep up with actually doing patients because I teach coding so often, plus I have to get recertified by every year. But we have 50 RN coders that are all extremely experienced. That's the only way they come on with us. And yet, we are constantly seeing emails back and forth between the coders and our coding manager to say, well, gosh, this scenario, and that's the problem. You can learn all of this, but case by case, many of our clients that we've had long term, they even text us and say, oh, goodness, in this case, what should we do? And that's what you have to do. You have to have that case by case, because PDGM's not easy, OASIS isn't easy, coding is certainly not easy. And then you have the other half of your patients that are managed care. So it's definitely not easy. We have so many home health startups right now. It's really amazing to me. And I think to them, do they really understand the complexities of what they're getting into? I try to tell them, but do they really understand it? This is not an easy industry. Then you definitely, for your coders, you need to have continuing education. And if you have problems, do the remedial classes again, do one-on-one, continue to audit, monthly on the ones that are having problems, but then quarterly. The auditing for us takes us a very long time. It is labor intensive to audit coders because our coding managers are literally having to go through and audit all our RN coders. And you have to look at the charts the same way, but it's so important to do. So make sure we do a lot of audits for agencies that code themselves or have another coding group. We literally are on the calendar for some agencies doing the coding audit. And then do trends per coders so that you can see where you are. The reimbursement, well, you have to make sure, of course, that your EMR system is excellent and can run reports and can do all this. So that's what you really want to look at. I'm not sure why. I just taught this last week, but it seems like everywhere EMR was, there's ER. So I figured that somebody ran a spell check and it changed all the EMRs to ER. So everywhere you see an ER there, it's actually EMR. All right. So in conclusion, PDGM is very complex. We hit a very big part of it, though, because we hit this process flow in your agency, and from referral, way out there, teaching your referral sources to your intake department, having your clinicians be knowledgeable, having an initial assessment done by phone during the waivers on questionable ones, and certainly on site for questionable ones after the waiver's lifted. And then your comprehensive assessment, having that clinician really capture all of the story of the patient, so much information we don't know, to the highest level of specificity and what's the underlying cause. Query the physician, make sure this is pretty consistent. Many of these scenarios came from our clients. And as we were just doing things for them, and it was at the beginning of PDGM, we went, these are going to be big scenarios, and they are. The only new ones are the COVID ones and the waivers. But it isn't easy. This is all the NOC toolkit, physician toolkit links. You can give a brochure, you can give a video, you can give a guide. You can give, it's really good. So you want to look at all of these, because when you get into all of these, you'll see, well, oh God, Mr. Jones's office, I need to do this because they won't listen to me. So, you know, you have a lot of different ways to do it. All right, like I said, obviously I'm 10 minutes over already. So please, any questions, even if you get off of the webinar so you lose the chat feature, here's my email. Feel free to email me with any questions. The ones that came into the chat, and Molly's going to send me, and I'll be sure to get back to you quickly on those. So I want to thank you so much for joining me today on PDGM Coding Scenarios. And now I can give it back to Molly.
Sharon, thank you so much for a lively presentation. That was wonderful, and we're really grateful for you joining us today. As Sharon mentioned, we will send out a link to the recording of this webinar along with a link to the slides. If you're still on the call, you can find the slides in the handout section of the GoToWebinar, the little box. It'll have a question section and also the handout, so you're able to pull the slides now if you'd like to grab them, if you don't want to wait for the email. And then, as Sharon mentioned, feel free to send your questions in. We'll get those to Sharon and have her follow up with you shortly. So thank you, Sharon, so much for sharing your expertise and your wisdom with us today. As we said, we'll send a link to the materials, and we'll get that out in the next day or two. And we want to thank all of you for joining us today as we work together to deliver on our mission to empower healthcare organizations and professionals with the world's best technology solutions. Sharon, thank you so much for joining us. We look forward to seeing you again.
Thank you, everybody. Bye.
Thank you for joining our on-demand training today. Axxess is the only home healthcare technology company approved by the American Nurses Credentialing Center to offer continuing education credits and the most recommended home health software on Software Advice. You can watch more on-demand training videos through our industry-leading help center or at axxess.com, where you'll find tutorials, blogs, white papers, and answers to frequently asked questions. Axxess, empowering care anytime, anywhere.